Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning.
And I'm Rhiannon Ashman, Pat's trusty sidekick and also deputy editor of MIMS Learning.
This is the first episode of the new year. Welcome back. I hope you've had a chance to rest and unwind over the festive season. Today we're talking about our new editorial campaign for 2025 entitled Patient, Presentation and Pathway for Cancer. And we'll be providing some insights about earlier cancer diagnosis. It's estimated, according to King's College London, that a typical full-time GP will see 8 to 9 new cancer cases per year. NHS England says that of the 290,000 cases of cancer diagnosed in the UK each year, most will come via a symptomatic presentation to primary care. And an average GP will see one of each of the 4 most common cancers each year. That's breast, lung, colorectal and prostate. And of course, these figures are the tip of the pyramid. For every cancer diagnosed, there'll be many referrals. NHS England says that 6% of all urgent referrals for suspected cancer resulted in a diagnosis of cancer between April 2022 and March 2023.
So that's 94% of referrals that didn't result in a diagnosis of cancer. So it's a lot of GP consultations prior to those referrals being made, let alone all the other consultations where GPs might have considered cancer as a differential and consultations where patients might be worried about cancer. So over the next 12 months on MIMS Learning, we're going to be sharing a lot of free content to support primary care with 3 key pieces of the puzzle to earlier cancer diagnosis. That is getting the patient through the door or onto screening, spotting the sometimes vague cancer presentations, and making most effective use of the referral pathways available.
Cancer is important as it can be a life-altering or life-threatening disease with a lot of anxiety associated with it, and the lifetime risk is very high. According to the Cancer Research Campaign, nearly 1 in 2 adults born in 1961 will get cancer. And cancer is an NHS priority. The NHS long-term plan aims to build on work to raise greater awareness of symptoms of cancer, lower the threshold for referral by GPs, accelerate access to diagnosis and treatment, and maximise the number of cancers identified through screening.
So Pat, I think it's a given that diagnosing cancer earlier is preferable to late diagnosis, but why is this a priority and what exactly are we gaining by making diagnoses earlier?
Well, late diagnosis is still a very real issue. For example, a report has shown that 4 in 10 cases of prostate cancer are diagnosed when there's locally invasive or metastatic disease. And we have a learning module on the NICE guidance on suspected cancer, which acknowledges that patients in this country are diagnosed at a later stage than those abroad, which has led to the reduction in referral thresholds seen in the NICE guidance. And the guidance states that there's considerable variation in referral and testing for possible cancer, which can't be fully explained by variation in the population. So there's a survival gap between the UK and other European countries, and so the NHS wants to improve early stage diagnosis such that by 2028, 75% of cancers are diagnosed at stages 1 or 2. And of course, early diagnosis means you have to have less invasive treatment than later diagnosis, could extend your lifespan. And for the NHS, as well as patients, it's massively important to save people having invasive, expensive treatments that can reduce their quality of life.
Yeah, and some elements of the cancer diagnosis pathway, of course, such as waiting times and available investigations, are outside of an individual healthcare professional's control. But I think this is a topic where it's really important to take a step back and see the larger picture of the role in general practice in earlier cancer diagnosis in terms of controlling what's within your control. So obviously we don't have to tell our listeners that there are substantial challenges for primary care around this. GPs are already working very hard to deliver all the consultations that they do, and cancer can be a real diagnostic challenge. We've got a short clip here that we wanted to play from our GP advisor, Dr. Ravi Ramanathan. He's a GP in Ealing.
There are some cancers that are commonly diagnosed late. And I mean, just to give you an example of a couple of these, one is bladder cancer in older women,
Right.
which presents with hematuria, which is blood in the urine. But hematuria can also be a symptom of urinary tract infections. So as an example, somebody could be treated multiple times with antibiotics for urinary tract infection, whereas in fact the blood is not coming from a urinary tract infection but from bladder cancer.
Right.
So that would be an example of a cancer that's diagnosed late.
Mm-hmm.
Another example is, for instance, ovarian cancer, again in older women, because one of the presentations is bloating of the abdomen, and sometimes that can just be perceived to be weight gain as people are getting older, and so that cancer could be diagnosed late as a consequence. Some cancers are just very, very difficult to diagnose, like pancreatic cancer,
Yeah.
because the symptoms that it presents with are fairly vague abdominal symptoms, which can be caused by so many other non-sinister causes. So there is a challenge, particularly in some cancers, if you're not aware of diagnosis being made late.
Yes, so as Ravi says, it must be really difficult to try and sift out the possible cancer from all the other possible causes of a patient's symptoms.
Yeah, one red flag that is commonly known among health professionals, although I'm not convinced it's that well known among patients, is unintentional weight loss. Weight loss, of course, is a common symptom of cancer, although it might have other causes as well. And we've got a red flags module on this on MIMS Learning. It provides really useful tips on additional symptoms to look out for that might indicate cancer.
Yes, for patients with unintentional weight loss, there's a table in this module that lists other red flags to look out for in the context of unintentional weight loss. So this is categorised by gastrointestinal, respiratory, gynecological, head and neck, so on and so on. So, for example, new lumps or lesions, other new onset symptoms such as change in bowel habit or new bleeding would raise red flags, and unexplained fatigue or persistent bone pain should also raise suspicion. So we're making this red flags module free as part of the campaign, and we'll put a link to it in the podcast notes.
Another consideration, I think, for primary care is abnormal test results. So our learning module on the NICE guidance on suspected cancer talks about the recommendations from this guideline on non-specific blood results. So some of these are obvious: colorectal cancer in a patient with unexplained iron deficiency anemia, for example, but other recommendations are potentially practice changing, the module author says. For example, new onset diabetes with weight loss in people aged 60 or over should raise suspicions of pancreatic cancer. Raised platelet count in people aged 40 or over might warrant consideration of lung cancer. Low hemoglobin or raised platelets with hematuria or discharge in women aged 55 or over could indicate endometrial cancer. And raised white cell count with unexplained blood on dipstick in people aged 55 and over might suggest bladder cancer. So there's really a lot going on here, isn't there? And it's difficult for any individual to always be aware of this vast array of signs and symptoms of cancer.
Exactly. And the GPs that we speak to acknowledge that the thought of missing a cancer is a worry for them.
Yeah.
And that this is perhaps particularly acute for GPs who are just starting out. But GPs do say that they start to develop what I've heard referred to variously as a sixth sense, a hunch, or your nose twitching about cancer. But it does take time for this to develop. And I spoke to Dr. Pipin Singh, a GP in Tyne and Wear, about this issue at our recent MIMS Learning Live event in Liverpool. So let's hear his thoughts on the matter.
You are more worried when you start off, there's no doubt about that. You've gone largely from being supervised by your clinical supervisor, you've got an educational supervisor in your training, you've got your peers around you whom you meet on a weekly basis at your training programme. Yeah. So lots of opportunity to debrief and so forth. So when you start off as a GP, you then all of a sudden go from having a clinical supervisor one day and peers around you to potentially not necessarily everything disappearing, but if you then go on to, say, locum or work in a new practice where you don't know anybody, you're largely independent and you may not have that support that you've previously been used to. So you are independent, and yes, there is that huge sort of burden, I suppose, on your shoulders of what am I going to miss today? How do I sort of mitigate that and so forth? So it takes time, but with obviously time you become more experienced, and I think with experience you then start to develop that sixth sense for sure.
That's really interesting. Thanks for that, Pat. It reinforces that general practice really is an art as well as a science, isn't it? And this is something that we want to support GPs with this year by providing some useful resources. So both Dr. Ramanathan and Dr. Singh, who we heard from there, were talking about the challenges of spotting cancer symptoms, or rather the difficulty of sort of discerning how concerned you should be about sort of vague or seemingly unrelated constellations of symptoms. But that's not the whole story, of course, is that?
No, you can take it back a step and consider what the role of primary care is in actually getting people through the door, as it were. We've been reflecting recently and talking to clinicians about the GP's remit for educating patients about what constitutes a worrying symptom, when they should present, what the barriers are for patients taking up screening that's available to them, and whether primary care can do anything to help overcome those barriers, and also how GPs can effectively safety net patients, as we've spoken about, the ones who might have vague symptoms or whose symptoms might not quite meet the threshold for referral.
And of course, to what extent can primary care be proactive in case finding? So taking account of people's risk factors and family history. I had a very interesting discussion with Professor Peter Johnson, who is Professor of Medical Oncology at the University of Southampton and National Clinical Director for Cancer at NHS England. And he talks more about that point exactly. So that will be next week's episode of the podcast, so don't miss that. And on the topic of being proactive, there's absolutely a piece about health inequalities in here, isn't there?
Sure. And this is something we've picked up in 2024 when we were running the Targeting Health Inequalities campaign. We know that some cancers disproportionately affect certain groups. For example, Black women are disproportionately affected by breast and endometrial cancer. Cancer diagnosis is also affected by deprivation. And this is covered in more detail in a conference report that we published on global trends in gastrointestinal cancers. The mortality rates for stomach and liver cancer in the most deprived areas are double the corresponding rates for the least deprived areas. For esophageal cancer, the mortality rate is 60% higher, and for bowel and pancreatic cancers, the mortality rates are between 20 to 30% higher in the most deprived areas.
And the patient profiles are changing as well, aren't they? So that conference report you just mentioned on gastrointestinal cancers, Pat, said that over the past decade, the incidence of early onset cancers, so that's cancer in adults under 50 years of age, has been rising for cancers of the colorectum, esophagus, extrahepatic bile duct, gallbladder, liver and pancreas.
Yes, just last month I saw a news report about a study from the Lancet Oncology which said that early onset colorectal cancer rates are rising in 27 of 50 countries studied. And this is a worrying trend. And I think we've already heard anecdotally from GPs who we talk to that they're seeing younger people with this type of cancer. So it's really worth GPs having these epidemiological findings on their radar.
Yeah.
And we also interviewed Professor Mike Kirby recently about prostate cancer diagnosis and treatment for this podcast. And he had lots of wisdom to share, including that he recommends looking beyond symptoms to try and pick up cases of harmful prostate cancer early. So let's have a quick listen.
Lower urinary tract symptoms are the obvious one, such as urinary frequency or hesitancy or urgency. Erectile dysfunction may sometimes be a presenting feature, or bleeding into the urine, visible hematuria. But that being said, 75% of prostate cancers occur in the outside of the gland, which means they're nowhere near the urethra. And therefore, they may not cause any urinary symptoms, and they may be very silent and then break through the prostate capsule before anybody really knows the disease is there. So I don't think we can rely on symptoms. The metastatic symptoms are often bone pain, such as back pain, and we don't want to see men with that. So I think we do need to be suspicious in men with those symptoms, but we need to be alert anyway. All men over 50. And remember that men who have a family history and their father or their brother have a 2.5 times more greater risk of developing prostate cancer. And black men are much greater risk. They're twice as much at risk as white men. So 1 in 8 white men will develop prostate cancer at some time in their lifetime. And, frighteningly, 1 in 4 black men will develop prostate cancer. And that is why, at the moment, we're really recommending a sort of risk strategy.
So Professor Kirby then went on to discuss the possibility of a more proactive approach to PSA testing, extending it to those at highest risk of the disease. And this is part of a national conversation around prostate cancer screening that gathered pace in 2024, and it's an issue we'll come back to this year.
Our colleague Sangeeta also spoke to oncologist Dr. Jay Naik about breast cancer diagnosis, and he talked about the role of GPs in genetic screening. Let's hear what he said about that.
This is mainly around taking an accurate family history. So one of the things it's worth encouraging ladies to do is have a proper discussion with family and find out as much as they can, because the detail of the family history is actually quite important in assessing risk. So this will be first degree relatives, so that's essentially parents and siblings and children, so mother, sister, daughter, and then second degree relatives, which might be grandmother, aunts, uncles. Men do get breast cancer occasionally, and there's a much stronger genetic link with male breast cancers. So I think the role, as I see it, is if a lady asks about screening, then I think the GP does have a role in that. If they can start that process, family history, and most places run what's called a family history clinic.
Yes, so as Dr. Naik says, there is a part for GPs to play in considering the patient's genetic risk during consultations.
Exactly. So we talked about case finding through screening and being proactive, as well as reacting to the symptoms that the patient brings to your consultation room. But another piece of the jigsaw puzzle is, when you suspect cancer, how to make best use of referral pathways to specialist services. Let's hear again from Dr. Ramanathan on this.
Obviously, there's very good protocols for referring under the 2-week rule, what we call the 2-week rule, but sometimes it can be up to 4 weeks.
Yeah.
And if GPs are fully aware of these, then they can use these routes to get earlier diagnoses. So I think having a high index of suspicion, but also of being able to process that, because if you referred everybody with an overly high index, then you'd swamp the system and cause delays that way.
Yeah.
So it's a balance, but obviously greater knowledge of any cancer and its symptoms and diagnosis increases the likelihood that it's diagnosed early.
Wise words from an experienced GP there. And we'll discuss referrals in more detail as the campaign progresses. For example, I've interviewed a GP called Dr. Sarah Bull, who runs a non-site specific cancer diagnosis clinic, and she's given us lots of learning points about making referrals in a way that's quickest and best for the patient. And we'll run a webinar about referral pathways later in the year.
So there we have it for today. Early cancer diagnosis, a huge conversation that's happening in lots of quarters, but I think it's really useful to break it down into these 3 areas that primary care can have an impact on. So the patient, presentation, and the referral pathway. So what have we got to look forward to as part of this campaign, Pat?
Well, we're planning to provide what help we can to GPs to support them with these pieces of the puzzle. There is obviously a lot of really good information out there already from charities and other organisations. For example, Cancer Research UK provides insight guides for primary care and an early diagnosis data hub. Mm-hmm. And Macmillan has top tips for healthcare staff on a range of cancer types, as well as on common symptoms such as fatigue, breathlessness, and gastrointestinal symptoms. And again, we'll link to these from the podcast notes. In terms of what MIMS Learning is doing, we're going to provide a set of learning modules for free during 2025. And this will cover things like red flag symptoms for certain cancers, webinars to hone your skills at spotting and safety netting worrying symptoms and navigating referral pathways, and insights from experts. And this will all be within the framework that we talked about, the patient, where at-risk patients need to be identified, encouraged to engage, and we'll highlight ways for GPs' practices to pursue this, as well as safety netting where appropriate. The presentation aspect, where GPs need to be able to spot those signs and symptoms that should prompt referral and have cancer at the front of mind. We'll provide learning around this. And the pathway, patients need to see the right specialist, and our learning will help for GPs to optimise referrals and make best use of local pathways. So we've launched a campaign page with some free learning resources on it, which we've given a link to. So keep an eye on what's new on that page.
And I mentioned earlier, the next episode of the podcast will feature an interview with me and Professor Peter Johnson. And he talks about how NHS England are approaching the challenge of improving early cancer diagnosis, how they're working with primary care, the success of the lung cancer screening programme, and some other targeted approaches to case finding. And he had some really inspiring updates on the successes so far. So I think if you feel overawed by the scale of the task, and who could blame you, you'll hopefully come away from listening to this next episode feeling inspired.
Great, thank you. I'm looking forward to that one. So, to conclude, there's constantly a national conversation around things like delayed diagnosis for cancer, the merits of screening programmes, and advances in treatments. We've decided to join this conversation with the specific aim of helping to support GPs in the three main aspects of patient presentation and pathway. We aim to help you influence factors that are within your control, keep up to date with signs and symptoms, and feel empowered to make changes to your clinical practice that may enable earlier cancer diagnosis. We hope the brief learning points we've covered today may be helpful to you in your practice. Thank you very much for listening. Don't miss the next 2 episodes because they'll be great. We've been the MIMS Learning editorial team, and this episode was produced by Till Owen. Don't forget you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. Thank you.